Hi, I'm Dr. Fulu Balogun, also known as Folu for short.
Hi, I'm Dr. Onyinye Balogun. We are the Onc Docs.
Our guest today is Dr. Selwyn Vickers. He is the president and CEO of Memorial Sloan Kettering Cancer Center in New York. He is an internationally recognized pancreatic cancer surgeon, pancreatic cancer researcher, and pioneer in health disparities research. He's a member of the National Academy of Medicine and the immediate past president of the American Surgical Association. Dr. Vickers joins us to share wisdom gained from building a successful career in academic medicine. He also discusses the imperative for academic medical centers to address the social factors that can adversely impact cancer care.
Who is Selwyn Vickers? Who is Selwyn Vickers? That's my question. I've read about you clearly, but
I'm a product of hardworking African-American parents who were educators, who had deep values and faith, excellence of character, and excellence of performance, and deeply cared about people. Fortunately, both of my parents loved people and loved serving people. And so I think inherently, I certainly brought to bear in my life and characteristics of really seeing my success at the end of the day lived out through the lives of others, and having the ability to desire to see those around me achieve their dreams is what I win by. One of the things that Charles Drew, who was the first head of surgery at Howard and who spent his research years at Columbia, when he couldn't eat with everybody, he had to eat by himself in the cafeteria, and yet was one of the critical individuals to work on blood groupings for the Blood for Britain program. He highlighted that at the end of the day, excellence of character, excellence performance often can overcome the artificial barriers put in place by men. And so part of my ethos was one of my medical school mentors, who was the dean of our medical school, reminded me, but he reminded our class, and two factors. He said that in the scope of society and healthcare, that many of you in this class will be in the middle of the world of how you do things, and you will do great work. Many of you will be in that crowded space at the lower part because there are plenty of people there who are doing good work as well. And he said, few of you will be at the top, but you must also remember, no matter who you are and where you come from, people will always make space for you if you want to be at the top. If you want to be the best, somebody typically will find a space for you. And it reminded me that in general, that excelling to be better than expected, somebody will always find room, even with their prior biases, will find often room to give you a chance to actually perform. And then fundamentally, because of my own sort of background where I came from, a fairly poor state, and even though I had done well in my world, going to a new world where people had more exposure, more training, and often more opportunity, I also had to realize principally not to let my point of entry be my determining point of exit. I may not have come in at the top, but I'm not going to go out at the bottom. And so that were many places where I, by perception or where I came from, there wasn't much impression that I was the best that they'd ever had. It was just hopeful I would be okay. And so I was fine with coming in sort of at the bottom or in the middle. But what I committed myself to is to go out, as with all due respect at my abilities, to go out at the top. And so that determination, through both a faith journey because of the background of my parents and my own personal life, have driven the desire to want to be both better than expected, but to be my best in what I've done, whether it's been, surgery and having the opportunity to take care of people who don't look like me on a regular basis, and transforming their thought process to being Okay, he's Black, so how did he get here? And am I going to the right person he's Black, and if he made it here, he's got to be good. And having that switch in the paradigm where the first one is, this doesn't look right, to the other one is, maybe, boy, if he got through, he's got to be good at what he does. And it reminds me of Desmond Tutu's story, which I probably shared in some venue, but it rings relevant to me, to the barriers we've overcome, as he was coming to Baltimore to visit and be a part of the Martin Luther King ceremony at Johns Hopkins. And he'd flown from Cape Town to Johannesburg and then had to get off of South African Airways because they weren't allowed in the US space because of our penalties against apartheid, our sanctions against apartheid. And he got on Kenyan Airlines, and as he walked up the stairway and saw two Black pilots, he said he'd never been more scared in his life. Everything he'd ever been taught was to ask the question, where is the white man to show you how to fly this plane?
Wow.
And that framing is that same sort of frame that we have not only lived with of how other people think about us, but it's also the framing of the impact of what we think about ourselves. Is that in many ways, we're not, in America, we're not even thoughtful enough to think we ourselves are the best, that there's something better than us. And the power of that idea, Tutu says, that nothing is more degrading to have a child of God think he can be something less than what he's capable of being. And that mindset is one that he said, everything showed me that's just not right. There's no good in that. Maybe if there were one white guy, certainly if there were two, I'd feel much better. But I feel totally incapacitated when I see that as the total guide. And so it's making that transition to where people realize that excellence comes in many frames in the world and many packages.
You know, I remember everyone was so excited in 2022, you know, whether they were MSK or whether they were New York Presbyterian or other parts of the nation, when you became the first Black president and CEO of Memorial Sloan Kettering. I think, period, we were excited that someone of your caliber, someone who's just had a really robust career as a pancreatic cancer surgeon and researcher, was coming, but it made it extra special that you were Black, of course. So what did that milestone mean to you, and why do you think it matters?
Yeah, I think it's a challenging time in the concept of thinking about it, largely because I think we forget that in so many ways, our country over its history has struggled. What role and what capacity and what abilities do people of color have? And no matter what origin you come from, whether you're Afro-American, Caribbean American, or born in Black America, you all get put into that label because of how we appear. And that's sort of like maybe only in America. I mean, as one writer said, as she was giving a lecture in England, the concept of being Black really is only in America. People speak about your origins, you're Nigerian, you're Cameroonian, you're Ghanaian, or you're Caribbean when you're elsewhere in the world. But only in America are you Black. And that scenario is driven by a past history that we haven't completely dealt with, that the intelligence, the capacity, the ability, the beauty is really not diminished by your skin color. And God didn't give any less to any race, as in the case of Black people. And so it still matters today because the legacy of the struggle of people of color in this country is still significant. And if we thought it wasn't, George Floyd reminded us it was. And we'd like to think it wasn't, but it is clear that in the world where you have not too distant in the past, where if you gave a doll that was Black and white to a little Black girl, she would always choose the white one as pretty. That's a world that we still live in. And that's a world where there is significance of when someone of color has a chance to lead. and lead because they have been given the sense that they have both capacity and opportunity like anyone. And just like you and your jobs, you don't think about being a Black doctor. You thinking about being a good physician. You think about doing your job well. It's paralyzing if you spend your day thinking about, okay, I'm a Black doctor in this role. There are occasions that comes up largely by actions and interactions. But when you wake up to do that job extremely well and as well as anyone else, in spite of the encumbrances and barriers you might have faced or face today. Not dissimilar from me. I've always enjoyed learning new places and learning new people. I've found in general, as you try to lead and care about people, the differences go away. They actually become less of an issue because you realize that at the core, we're not very different. And yet we may have had distinctive journeys to where we and how we got here. Great to learn about them, great for us to know them. But at the end of the day, we're hopefully all rowing in the same direction. I bring a set of experiences and views that are hopefully valuable because I come from a diverse background compared to where MSK may have had leaders before.
Mm-hmm. Mm-hmm.
So I think it is important because of our history. I don't languish in that because I do think there is a point that we can get to that's better for the entire country if we're willing to acknowledge that history and actually refuse to repeat it.
Mm-hmm. Mm-hmm.
So some of what you said. So I have been fortunate to hear you speak a couple of times, and I'm really excited about this opportunity whereby more people will hear you speak. So speaking of this legacy of color in the US, in our country, when I do research, a lot of what I do is looking at understanding the genetics of cancers, and I focus on underrepresented minorities. But I always lead with a sentence that says, I am not saying that race is genetically defined, but we have to acknowledge that race does play a role in health outcomes, health identification and health. So thinking of going back to this legacy of color in our country, you've done a lot of work to help inequities in your previous role in Alabama, and I would like to hear more about what it is that you did and also how that would translate to a different place here, like which is New York, MSK.
So Folu, I appreciate what you began with in the context that race is a social construct, and people might argue there is only one race, that is the human race. But in reality, it is a social construct that is in part where we live. And that social construct, however, has created differential environments. And although genetics are a human issue, the modification of the genes in the space of social epigenomics is real, right?
Exactly.
Having where you've grown up and the stress you've been under and the environmental exposure you have does affect your genes. Even though you may be born very similar, it has an effect by virtue of what your environmental circumstances and the pressures that it has produced on your physiology. And so there is a purpose for that role of saying that, yes, genes are often similar, but the modification in the context of social epigenomics is real, and we can't ignore that. And if we're going to be comprehensive and being able to care for people broadly in our country and the world, we have to really embrace those diversity areas and make sure they're included. I think to answer your second part of your question in the context of what did I see, and I would argue both in Minnesota and in Alabama, is that disparate communities, by virtue of their history and legacy, often have their health determined by social factors, right? And whether you're an American Indian or African American, in Minneapolis was the largest home for Somalis, for Liberians, for Hmongs, who all had their social determinants that affected the outcomes of their health, just like poor Blacks in the South.
Dr. Vickers is referring to social determinants of health. According to the Centers for Disease Control, these are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Examples of social determinants of health include your level of education, the neighborhood you live in, and your ability to access nutritious food.
And those social determinants are 70% of the drivers of our healthcare outcomes. And they are fundamentally related to education, access, economics, really critical drivers, food insecurities. And I would say what I've learned, Folu, is that if there is an area that academic medical centers are least equipped to deal with, it's these social determinants. We are really largely equipped to deal with medical determinants of health. And that's our natural sweet spot. And yet we are often the biggest resource engines in our communities. We provide the jobs. We provide the economics for those communities. In some places, like Baltimore, Birmingham, the largest employers are hospitals. I mean, they're the driver of the business model. And so, although they're not designed in their sort of initial origins to do more than just deliver healthcare, in the reality of the world that they live in, academic medical centers have to partner and branch out to support and address social determinants of the populations they care for. So what I've learned is you got to figure out where the resources when it comes to kids learning how to read at a young age. You got to learn how you can provide child support and what the resources are for single parents and working moms who are trying to get their kids educated. You got to provide access. So for when someone's a part of a clinical trial, you got to provide services sometimes for them to get to that trial destination on a daily basis or to get that daily radiation therapy. You then often have to provide transportable services for healthy foods. In the food desert, you have to bring in trucks that bring in fresh fruits and green vegetables that sit alongside the Popeyes chicken and the McDonald's, which are often the only choices that many people have in those areas, particularly affordable choices. They may have a grocery store, but it's beyond what they can afford. And it's cheaper to buy, a $2 hamburger or $2 where you can get 3 hamburgers, the cost of lettuce and vegetables to be on the same trajectory. So I think it's really a cultural landscape shift where AMCs see that this is fundamental and paramount to actually producing good health and treating medical problems, and understanding that they don't have to own it all, but they can be a guiding entity in bringing those resources to bear that are often in the community, but are just not connected to the people with needs.
You mentioned AMCs. I'm sorry, what's that?
Academic medical centers.
Okay, got it. Thank you. There are 2 questions that come to mind for you, right? The first is, when it comes to these social determinants of health that we are not so well equipped to address, but we need to, especially when it comes to research, I think. How do you build that capacity? What's happening also specifically at MSK to build that capacity to do that sort of research? And then I love your understanding of we need to do more than just say, oh, here's a clinical trial. There are barriers. I think ASCO came out with a publication just talking about how our huge concern of not unduly pressuring people, or enticing people into clinical trials has now turned into, we are averse to giving them transportation. We're averse to giving them, incentives that may pressure them into a trial. But then that makes people who have, these maybe lower socioeconomic status not able to participate. So how do you strike that balance? And, what are you putting in place in order to make sure that there's that equity in terms of providing for people what they need, rather than just this across the board, this is what you're going to get for this clinical trial?
It's a really good question in the context of a place like MSK, but many others that are really busy trying to conquer the next sort of cancer treatment cure in front of them. I think practically it's first valuing the fact that we can be better and have a chance to be our best if we commit ourselves to inclusive excellence. That has to be the grounding, because it gets tiring sometimes. It's not easy. It's not often right in front of us. We have to go out of our way to make it happen and to think extra. So that's first. Secondly, so it has to be a core value. I think secondly, it also is important to understand that part of taking on this problem, it's a big elephant. And the approach that many organizations take is a shotgun approach. You will find that in many worlds, when you step into the community and dealing with the lives of people, when it comes to that public business interface, often the most trusted entity to step in to do something in a neighborhood is an academic medical center or a hospital. Is that businesses will come alongside often a hospital when they're trying to address a need that is fundamentally, at the end of the day, linked to somebody's health, whether it's housing, whether it's shelter, whether it's reading, whether it's food. You'll find more often in those spaces where a major corporation like an Amex or a Travelers or a Citibank, which has no capacity to go in and build a reading program or build, supermarkets, that's just not within their purview. But they have financial resources if there was someone who was standing in the gap to say, we're going to work to provide an interface with the community if you are willing to put the resources to actually help deal with this social determinant. So that third piece of finding true collaborative partners, and that collaborative partners can extend to those with resources that are completely outside of the medical world but have a social conscience. And that collaborative partnership can also be community-based services that are already funded, but just simply are not connected to people in need. And then finally, that partnership can be partnering with other institutions that in the context of what you do are like yourself, they're hospitals, but where they do it and who they do it for are very different than you because of the population they work in, the areas they work in, and because of the trust that they have built in those areas. So I think that collaboration then with those partners is fundamentally important. I think then applying the resources that often are in those areas where they don't have expertise with dealing and they have a social conscience to do so, as well as linking the resources that are already in the system but are still not connected to the individuals in need, and then providing the guiding entry point for the opportunities for care because you've addressed their needs that often that drive care that wouldn't be there if you made their needs go away. If you dealt with their needs, they wouldn't show up to the ER because they didn't have a refrigerator for their insulin. If you dealt with their needs, they wouldn't run to the ER had they been able to make their last appointment to see their cancer follow-up. So all of those things would actually really put in place true needs being addressed in the healthcare world because you've taken care of those pressures that often drive care that's really driven by social determinants or the lack of that support.
I really love what you're saying because it's saying that the academic medical centers, the hospitals should really look at themselves as community organization. It really reminds me of things that I learned or I experienced early on in training where it almost felt a bit helpless sometimes when I'd see a patient come into the ER, would take care of them, send them back out, knowing exactly they'll be back the next day because maybe they were homeless. Maybe they didn't have, we're giving them these medications, but I just know that they don't have the ability to see someone to refill the medication. So when it finishes, they'll be coming right back. And it just felt that there's more that contributes, it was very obvious, to the health of the community than we were given. And it just felt helpless that we couldn't make a big difference overall. This is a very, very good way whereby the hospitals, the academic medical centers, the larger hospitals would view themselves as, all right, we will facilitate not just the direct medication healthcare, but everything else that contributes to it.
And I think, Folu, you having history and potentially family that have lived in other worlds. You understand the wealth of America. I mean,
Oh,
we
yes.
throw out enough food to feed the world, right? They just throw it out. And you also know the resources that exist in our country that just don't exist elsewhere. What I would say is that for many academic medical centers like MSK, we've toiled and spent so much of our time in the space of therapeutic innovation, right? Everything we think about innovation is what's the next target? What's the next immunotherapy? What's the next critical biomarker? What's the next theranostic tool that can link to identify a targeted disease? What's the next biologic? But there is equally an opportunity to innovate in the space of how we deliver care and meet the needs of our patients. It doesn't mean that we just have to go find a new pot of money. It really often means somebody innovating to use the resources that already exist to take care of a problem that simply wasn't a priority for the institution. And that is, I think, the real space we have an opportunity is to really innovate when we see these problems versus to say, that's not my responsibility.
So with this shifting of priorities, right, I'm guessing not everyone is clamoring and saying, sign me up. There may be some people who don't think that that should be the focus. How do you get them to see that this is an opportunity and that this should be one of MSK's CC's lanes?
You know, I think it requires leadership, and it's not just the idea, here's my thoughts and my ideas and my priorities, so you got to do them.
Yeah.
It's really about building trust that what you believe is valuable for their organization is good for everybody.
Yeah.
And I think principally, one of the things that you can hang your hat on in the context of improving disparities, when you do ever improve an area of disparate care, you improve care for everybody. When you learn how to take care of a problem when someone has a disparate outcome and you make that problem better, you actually improve care for everybody.
Agreed.
Right? And so it takes the time and effort to show that there is value in it. And it takes the commitment to be in it for the long game. And it takes the commitment to do it in a process that actually brings value and not potential harm, by virtue of how you financially roll it out, by virtue of how you understand you're not going to have 100% adoption, right? And you will always have people who may not understand its role or appreciate its value. That's fine. That's going to be the case. And yet that doesn't lessen the value or the benefit that it derives. And then I think, like many things to change culture, you have to have data, right? It has to be driven more than by emotion and feeling and passion. Yeah. There has to be data to bring to bear the improvement, the outcomes, as well as the future opportunities that you see at hand.
Data. I love data. Oye teases me about that. Everything, it seems like I'm like, okay, where is the data? Where is the evidence?
No, I believe your phrase is, in God we trust. Everyone else needs data. So.
but it's true. It's true.
Unfortunately, our episode was cut short due to technical glitches. However, we hope that you've learned from Dr. Selwyn Vickers a bit about who he is and what drives him. We also hope that you see that there is certainly a role for healthcare institutions in actively addressing cancer inequities. Thank you so much for taking time to speak with us, Dr. Vickers. For more information about our podcasts, visit our website, www.theoncdocs.com. Please subscribe to our podcast on Spotify or Apple. And if you like what you hear, please give us a review on Apple.